Okay, good morning. We're going to go ahead and get started here. Probably going to wrap up bones today and start moving into muscles. Lab this week we'll be going over the muscles of the human body again. So, and in anticipation, obviously, of lab test 3. And you probably all have seen by now that all the exams after lecture exams 3, 4, and 5, and lab exams for 3 and 4 have all been pushed back till December the 9th. December the 9th is the absolute end of the semester. They cannot be extended past that. So don't wait till the last minute to take your exams. Take them as you're ready for them. But there is no, I've tried to remove some of the pressure of having to meet a certain date when it's just a whole lot easier just to focus on the end. So anyway, anybody have any questions about that? Okay, then I'm going to go ahead and get us into our lecture. Now, when we ended up last Thursday, we were talking about fractures. This is the last picture we saw. This is, of course, the classic hip fracture. Very common in elderly people, particularly your postmenopausal female. No, I don't like, while it seems like I'm throwing the postmenopausal female under the bus every day, that's really not the case. It's just that when, postmenopause, they have less estrogen, and estrogen stimulates osteoblast activity. And without estrogen, without a lot of estrogen, you're not going to get a lot of osteoblast activity, a lot of bone buildup, depending on whether or not they've had healthy lifestyle up to the point of menopause, with lots of calcium in their diet and lots of exercise. That's going to dictate whether or not they're going to have problems later in life. So, classic stress fracture at the hip, the neck of the hip shatters, neck of the femur shatters. It's not really the hip itself, but it's the neck of the femur because there's nothing left underneath the outer layer of compact bone except nothing. The spongy bone has been eaten away by osteoclasts to provide calcium for other activities in the body. And so the lysosomes go after the spongy bone because it's easy to dissolve. It's easier to dissolve that than it is to dissolve compact bone. And so they eat away all the spongy bone. There's nothing left except this hard outer shell, which shatters easily. Now, one thing to keep in mind is that you don't want to say that 100% of all hip fractures are the neck of the femur, but most are. Most of them are. When someone breaks their hip, it's nearly always the neck of the femur that's breaking. But people are unusual and we break things in strange places. And so a hip fracture can actually be one of the 3 bones that make up the hip. The ilium, the ischium, or the pubis. But it's usually always referring to the neck of the femur shattering. When we have an injury, like a fracture, we got to fix it. At least, we try to anyway. The thing to remember, though, is that fractures are going to repair themselves, whether we do anything to them or not. A fracture will heal itself. It may not heal in the ideal manner, but it will heal itself. We prefer to have the bones be put back in their original position so they can grow back together like they were before. But if we don't, they're still going to grow together. 2 terms. Well, the big term, of course, is reduction, realigning the broken bone. Now, if the bone is not displaced at all, then there's no realignment necessary because the bones are still lined up. If the bones are skewed off center, then generally traction is applied the structure involved until the bones can be manipulated in until they're lined up together. This can be done. This can be done from the outside, manipulating the arm or the leg or the finger or whatever to line them up. Okay. Go. Okay, taking attendance. So you can manipulate the bone from the outside, and you can actually feel the ends of the bone grating against each other as they get lined up. And there you go, closed reduction. And then all you need to do then is immobilize. And which the bone's going to try to do on its own anyway. Open reduction requires surgical intervention. You have to open up the tissue, and you generally involve putting plates and screws and wires and bolts and pins into the affected limb where the fracture is, because usually it's a displaced fracture with bone fragments all over the place, and they have to be pushed back together again and wired together, and you have to hold them in place so they'll grow back. And depending on how the type of injury, that's what you have open or closed reduction. And the more the greater the trauma, the greater the bone is displaced, the greater if there is an open a compound fracture where bone sticking through the skin, it's going to require extensive work. Generally, we try to immobilize the bone after an injury, with a splint or a cast. And casts have come a long way over the past 50 years, from heavy plaster casts with boards wrapped around by gauze and covered in plaster, massive weight here on the leg or the arm. And now we use, fiberglass or even lighter materials, some sort of acrylic plastics can be used for a cast. The walking boot is used with fractures of the foot or the ankle. Numerous types of treatments. We know that the more active a person is after the injury and after the repair, the quicker the bone's going to heal. The old process of immobilizing the bone and immobilizing the patient actually extended the amount of time it took to heal, and also, it could lead to other complications. Because if you immobilize the bone and immobilize the patient, they're going to lose muscle mass, they're going to lose bone mass. There's always the risk of developing pneumonia if they're immobilized flat in their back. And the sooner that your patient is up and moving after the surgery for reduction, the better off they're going to be, the healthier they're going to respond. This is an open reduction of the tibia. And this tibia was shattered in several places, and you can see the fracture line right there below that third screw. And so we see 3 screws, and like there's a plate in there that we don't see, and we have 4 pins embedded in the bone to help stabilize it. The pins will get removed usually, depending on their size, but the screws and the plates will stay there. And this type of procedure look like this. When you open up the tissue to expose this, and from the outside, we see this. We see that there are the 3 pins going through the leg right there. Those are rather large pins, but they will be removed. Smaller pins, if the pin doesn't penetrate through the surface of the skin, the pin is often left in place. Here we see a fracture of an ulna and a radius. This is a displaced fracture It doesn't look like it was an open fracture though, but this is likely from a fall. You know, because when when you fall, you put your hands down, and depending on the forces there, it just occurred to me, another cause could have been an airbag deployment. You know, if the average driving position is your hands on the wheel, you know, at the sides, or one hand maybe, 10, most of us don't drive at the 10 and 2 position like we're supposed to. But when the airbag deploys, it often throws the forearms back with great force. And it's not unusual to have fractures of the ulna and the radius from the deployment of the airbag. So it is a pretty powerful force. Fortunately, it doesn't it deploys so rapidly you're not aware of it, but then you can't move your hands afterward, or you can't move your hand afterward. So, but here we see plates and screws. Those are the staples, those little round things with the staples there along the side that are used to close the skin. And we know, and that's a quick way, quicker than suturing. I will say from painful experience that I think staples hurt more coming out, a lot more coming out than they do going in, but that's another point. Anyway, the bone's realigned. We've reduced the fracture, and then the bone itself, with the ulna and radius both damaged, but new bone will grow over these plates inside here, and the bone will be essentially as good as new, probably stronger. So, now, hip replacement, we saw this in labs. I'm not going to beat this in the ground. Again, we see that there are numerous types of artificial hips, usually made of titanium. You have a new head and neck of a femur, with a new acetabulum in here, and depending on how far down you have to go into the shaft of the femur, that's dictated by the amount of damage caused by destruction of the spongy bone. But this is a very, very easy approach. Lots of people I know, older people I know at church, for example, have had hip replacements that have done very, very well, and knee replacements that have done very, very well because of this. So it simply replaces the damage caused by osteoporosis. I also know lots of older people that haven't had knee replacements and haven't had hip replacements. A lot of it has to do, again, with particularly in your postmenopausal female, what was their activity level during their reproductive years? What was their diet like? Did they smoke or not smoke? Things like this. Anything that's going to interfere with maintaining high levels of calcium in the body, good osteoblast production is what's going to be the driver. It's going to push a postmenopausal female towards osteoporosis or not. Lots of older women in their 80s don't have osteoporosis. Many might have the beginnings of osteopenia, a condition where they're starting to see osteoblast activity not keep up with osteoclast. But at 85 years old, that's not going to be a big concern at that point in life, because it's going to take a long time for osteopenia to slide into osteoporosis. And lots of older people are very physically active, and maintain good, healthy diets, and that's going to resist a lot of that. Anyway, hip replacement, as I said, it isn't always about the calcium. It isn't always about the spongy bone being destroyed underneath here. The hip can, the socket can become inflamed. The head of the femur can become inflamed, and it's just, when it hurts. The thing is, when something hurts, we don't use it. If it hurts to move our fingers, we don't move our fingers. If our knee hurts, we try not to, we avoid walking. If our hip hurts, we avoid walking and exercise. And so, it sort of compounds itself. The more that it hurts, the less we do. And so the less we do, the more it's going to hurt when we do try to move. So we put in these artificial hips and artificial acetabulums, and we get our mobility back. And I've already gone through this in lab. Our knees wear out too. It isn't so much osteoporosis. It is arthritis and wear and tear. As I said before, 85% of us are going to develop osteoarthritis as we age. Has nothing to do with cracking knuckles or things like that either, by the way. It's wear and tear. And our knees get the brunt of this all the time. And so we can replace them if necessary. We take out the worn material and put in an artificial menisci and new artificial condyles on both the tibia and the femur, and our knee is essentially as good as new or better. So now, when we do have a fracture, there are 4 steps in the healing process. First thing that happens is we have a hematoma. That's a big blood clot that forms because we've torn tissue. We've damaged tissue here. We've damaged blood vessels. The fracture rips open blood vessels because we have lots of blood vessels running through our bone to keep the living cells, the 40% organic component of the bone, alive. And so we bleed, and we have swelling, and we have pain. Swelling occurs because fluid's going into the interstitial spaces. And the level of fluid that goes into that interstitial spaces, whether it's blood or just plasma, is more than the space is designed to hold. So we press against pain receptors, and it hurts. So we have pain and swelling and redness because there's more blood going in there. And then eventually that will go away as the swelling goes, as the bleeding stops and the swelling goes down, and the red cells and the plasma are reabsorbed back into the blood or back into the tissues. The swelling goes down and the pain goes down. So that's the first thing that has to happen is we have this response to the injury. Can't help it. That's what we do. The second thing that occurs almost immediately after the swelling, after the bleeding stops, is to develop a callus, a band of fibrocartilage, sort of like the same material that makes up the pubic symphysis and makes up the intervertebral discs. And we run fibers through this callus. Callus is like when you work and you get this tough skin in your hands, that's a callus, or tough skin on your heel of your foot, that's a callus. We get a callus, a band of tough connective tissue around the site of the injury. It's still flexible, but it's now surrounds the site of the fracture. And we see blood vessels penetrating through here, through the injury to reconnect on both sides. The third thing then is we convert that cartilaginous callus, probably within a week or two, the fibrous callus, we convert that in a week or two after the fracture to bone. We convert that into a bony callus. It's sort of like we're making our own splint at the site of the injury. And we're laying down some compact bone and some spongy bone. And then and it stays that way for about 5 or 6 weeks. Once our bone, the injury has healed properly, which takes about 6 weeks or so, then we start remodeling to get us back to the original shape. So typically a fracture will heal in 6 to 8 weeks, whether we do anything about it or not. Consider a fracture of your finger, of your phalanges. If you've ever broken your finger, usually it's a longitudinal fracture running the length maybe of the first or second or both the phalanges, on the distal phalange, maybe the one right behind it. There's nothing you can do. You tape your finger together, and the healthy finger works as the splint for the damaged finger. Maybe you put one of those metal splints on there and wrap tape around it for a couple weeks, and it heals up. It's going to heal on its own. The reason that we immobilize this so it doesn't hurt anymore, and so it doesn't get any worse. It's just, that's all we do. It's going to heal on its own. There's nothing we have to do to make it heal. And the best, if once we've reduced the fracture, if we had to, then the best that we can do is immobilize and then get out of the way and let the body do its own repair work. So the initial injury is going to hurt because of activated pain receptors from the trauma and from the pressure of the bleeding into the interstitial spaces. And the swelling that occurs. Pain receptors are not used to being exposed to this extra pressure. It's gonna hurt for a day or two. It's gonna be red. It's gonna be swollen. It'll be that redness is the inflammation. That's not necessarily a bad thing. Inflammation, the inflammatory response, is our body's way of responding to trauma. Bringing in more red cells with oxygen, bringing in more glucose, bringing in more white cells to kill bacteria is all part of the inflammatory response. So inflammation is not necessarily bad. Inflammation on a small scale, localized like this, is a pretty good thing. It's designed to treat the injury, to help repair it. The cartilage, the callus it forms, is made of collagen fibers. It's made of fibroblasts. Like the areolar connective tissue. You're going to see that come together to start knitting that callus. Osteogenic cells, the bone-forming stem cells, are going to start laying down, generating osteoblasts, start laying down a matrix, and we get this band in here of this callus, this flexible cartilaginous band called the callus. We're going to see the bony callus forming within a week or so of the fibrocartilage callus. Then we start laying down compact bone and spongy bone, and then we finally remodel and we're done. So now, all of this depends on how healthy the bones are, the type of the trauma, the food that we eat. Are the bones healthy? Was the trauma severe? Was there a lot of invasion of bacteria present? Was there surgical intervention? Was there the trauma of the surgery that's going to slow down the healing process? Because we don't like surgery, it is trauma when our bodies don't like it. How healthy are the bones? Is there adequate vitamin D present to make sure there's lots of calcium available for the repair? So we have to have lots of calcium in our diet. Bones require calcium. They require phosphorus. The crystals of calcium and phosphorus are embedded in the osteoid, in the matrix, and then wrapped with collagen fibers to make the bone very strong. Repair depends on more calcium being available to lay down new bone. So where do we get it? Well, we get calcium and phosphorus in our diet. But there's a catch. The ability to absorb calcium and phosphorus in our diet, like leafy greens and dietary and dairy products and stuff like that, all high in calcium, The ability to absorb calcium and phosphorus across the small intestine depends on the presence of activated vitamin D. Vitamin D is a steroid it's actually called cholecalciferol. Cholecalciferol. And it is usually made in our skin. When our skin is exposed to ultraviolet radiation, we generate vitamin D. Now that vitamin D is not activated. It is the inactive version. That is the cholecalciferol. The vitamin D that we take in through dairy products in our diet, or leafy greens in our diet, or in our vitamins are not activated. We have to activate the cholecalciferol so that we can absorb calcium and phosphorus across the lining of the small intestine. And of course, we also, we need C and A and K and B12 for bone growth. Now, not as much, B12 is primarily involved with red cell production. K is primarily involved with the whole clotting mechanism here. So A does more for the retina, and C is more of an antioxidant, but we need all of those to help with bone growth. Now, so we generate vitamin D in our skin, or we get it in our diet. We have the liver and the kidneys work together to convert the cholecalciferol into what's known as calcitriol. Calcitriol is the active version of vitamin D. The cholecalciferol has been changed. And the active version then allows the small intestine to absorb calcium. Calcium won't go across the membrane of the small intestine unless cholecalciferol is present. So we can stand out in the sun all we want to generate vitamin D. We can take all the vitamins we want, but unless that vitamin D is activated by the liver and kidneys, we're not going to absorb it. And we have to have calcium present too. We have to have calcium in our diet. We have to have calcium present in our diet. So the, dairy products are great because dairy products give us vitamin D and give us calcium. Food that's high in calcium and high in vitamin D are ideal. Calcium shows up everywhere. Calcium's even calcium is present in orange juice, not naturally, but it's added in. So the food industry recognizes that calcium is pretty important for us. So we find lots of foods high in calcium as an additive. Anyway, vitamin D is how we get the calcium, though, into our blood. It's the only way. It has to get absorbed through the small intestine wall. Now, problems with bones. Some of the more interesting things that can occur here now. 3 major bone diseases that we encounter: osteomalacia, and the childhood version of that one is called rickets. Osteomalacia means soft bones, weak bones, poor deposition of calcium. Either an absence of calcium or not enough vitamin D. In adults, we call it osteomalacia. An individual with osteomalacia may be standing in line at the bank or something and suddenly have their leg snap because the bone decides it can't support the body weight anymore. With rickets, we generally see the legs being bowed outward or bowed inward because they can't support the weight of the torso. So they have this give. They act more elastic. And plus they're very long and skinny looking too. Osteoporosis and osteopenia. Osteoporosis is when we have breakdown of bone by the osteoclasts at a faster rate than the buildup of bone by the osteoblasts. And we're dissolving away spongy bone at an alarming rate. Osteopenia is the precursor of all this. Osteopenia is when we have a little bit of breakdown occurring at a slightly faster rate than buildup. And osteopenia can be, bone density will tell you this. Lots of older postmenopausal females may have symptoms of osteopenia, and they stay that way for years. Paget's disease is a viral disease that stimulates excessive amounts of osteoblast activity, but the bone that it lays down is weak. And so we get this enlarged bone in different parts of the body that doesn't make any sense. Excuse me. With Paget's disease, you see one femur may grow twice its length, or a tibia may grow twice its length. The pelvic girdle may enlarge. The skull bones may enlarge, while the other half of the skull bones are not enlarged, or one arm is longer than another, or one leg is longer than another, and then it goes away. And we don't know why it happens. And the bones are weak. They get bigger, but they're weaker. Lots of times in the body, whenever we have excessive growth occurring, bigger is not always better. When the thyroid gland, for example, can't produce thyroid hormone, it will often enlarge and get bigger in an attempt to try and produce more thyroid hormone. If it can't produce the thyroid hormone, it will enlarge. Doesn't do any good. It just gets bigger and bigger. Our heart will enlarge. If a person has heart disease, and the heart will try to enlarge its muscles to get bigger to compensate for a weakness. Only the bigger the heart gets, it actually gets weaker and weaker in doing so. And it pumps less and less. It becomes less efficient as it enlarges, which leads to even greater enlargement. So I've seen in cadavers and a heart as big as a football, in the chest. It's like this massive heart, and the person died from heart disease. So let's see. What is the name? Heart being large. Usually the heart is cardiac myopathy is when the heart has enlarged and it's gotten very weak. The entire term for a heart attack is myocardial infarction, caused by a blockage of a blood vessel in the heart. I think myopathy might be the term we're looking for that. I'll have to check on that to make sure there might be another term. Myopathy is when the heart enlarges and can't do its job. And the heart then just wears out. Heart attack, enlarged heart. I'll get back to you on that one. So, okay. Anyway, so those are the three diseases. Now, conditions that occur, gigantism. Gigantism starts in childhood, where the anterior pituitary is secreting growth hormone at high levels. And so your individual starts growing. Long bones are being overly stimulated and they're gonna grow. And this will continue from childhood into adolescence into adulthood. And it's not unusual for an individual with gigantism to exceed 8 feet tall or more because of the overproduction of growth hormone. Second condition that occurs is called acromegaly. Now, acromegaly occurs after the long bones have closed. The epiphyseal plates have closed. What happens here is the pituitary gland starts secreting growth hormone again, and we get an enlargement of the facial bones, and often the fingers and the feet too. The hands, feet, and the facial bones enlarge. And so we see a very pronounced and very large chin, a very large nose, a very large forehead. The frontal bone gets very big. We also see the hands enlarge. The fingers become clubbed. They're rounded on the edges because of this. And the feet get very big. This can occur, over later in life. It usually starts showing up as early as the 30s, and then progresses. One of the characteristics also of gigantism and acromegaly is it alters the ability to speak. Because if you have gigantism, you're going to have acromegaly, because the facial bones are going to grow too. So if you have gigantism, you're going to have acromegaly. But acromegaly doesn't mean you're going to have gigantism. Lots of individuals of normal stature, or I should say average stature, that have acromegaly are, they're not 8 feet tall, they're, 5 feet, 5.5, 5 feet, 6 feet, 4, normal body stature. Their body stature didn't change. It's just that now their facial bones are enlarging. But it alters their ability to speak because it alters the size of the mandible. And so, our ability to make sounds is how we manipulate passage of air with our teeth, and our tongues, and our mandible. And often the ability to speak is significantly compromised. The voices that are produced tend to become more nasal in sound. So anyway, that is acromegaly, growth hormone after the long bones are closed. Pituitary dwarfism occurs when growth hormone levels do not get released at what we would consider to be a normal level. It's hyposecretion of growth hormone. We don't release enough of it during childhood. So your individual with that's hyposecreting growth hormone never gets above about 4 feet in height as an adult. Now, we don't generally see a lot of pituitary dwarfs anymore. And that's the term, pituitary dwarf, because they can be treated with synthetic growth hormone and achieve an adult, what would be what's considered a normal adult stature. But it's not a genetic condition. It's just a malfunction of the anterior pituitary. It didn't release enough growth hormone. So you can treat it and bring them, allow them to achieve, what would be considered a normal stature. And so we don't see, the use of synthetic growth hormone has really has eliminated most of the occurrences of this that we see. This is not the same thing that when we see with what we call the little people. I don't mean to be sarcastic, but the what we call the achondroplasiac dwarf. Here. Now, the gigantism, it generally, why does the pituitary gland malfunction? Why does acromegaly malfunction? Why does acromegaly occur? I think it's more of a mutation of the gene than anything else. You don't seem, you don't see offspring or other family members that have someone who is experiencing acromegaly or gigantism. You don't see their children experiencing it. You didn't see their parents experiencing it. So it's more of a mutation than anything else. Now, congenital scoliosis, that is a condition that can occur. I don't think it's considered a disease in that aspect. I think it is becomes more of a, I guess it may even be considered genetic here, because, you know, is it a mutation or is it inherited? But it is a, it is not usually generally not considered a disease. So, good questions. Now let's take a look at some of these now. Osteomalacia and rickets. Osteomalacia in adults, rickets in children. The bones don't mineralize properly. The bones are soft, they're weak, they can snap when load bearing. Not enough calcium being deposited, regardless of the calcium. What's the cause of it? Well, are they producing enough vitamin D? Are they converting enough vitamin D? Are they getting enough calcium in their diet? Why aren't they absorbing calcium? Why are the bones soft? In rickets, the legs are bow-legged. The bone ends get very long. You can see here is a femur, and look how it's, first of all, it's bent, but also look how long the ends are. Nearly always caused by either an absence of vitamin D or enough calcium. Now, are they missing calcium in their diet? Are they missing vitamin D, in their diet, or are they not getting exposed to enough sunlight in here? And so we have this weakness in the bones. The bones are very, very soft and fragile. They can't support the weight of the torso. And it's interesting that if you've ever seen A Christmas Carol, the Dickens movie about Ebenezer Scrooge and Tiny Tim, and lots of physicians over the years have speculated what was wrong with Tiny Tim and why was he going to die? Well, and why did he use a crutch? And there's been a lot of emphasis on perhaps he had rickets, because it would be perfectly normal in that time of in London to not understand the role of calcium. Calcium was something that was probably not in a lot of their diet at that point. A lot of leafy greens probably were beyond the ability of poor people. The Cratchits were not exactly wealthy individuals. They couldn't afford a good diet, and the air quality was very poor because it was in the height of the Industrial Revolution, and the air was dirty in London. So vitamin D production in the skin probably didn't happen a lot, and for whatever reason. So the speculation is that Tiny Tim may have had rickets in here, and it was killing him slowly. And towards the other side is, what about the rest of the Cratchits? Why didn't they all have it too? Don't know, but that's one of the speculations about Tiny Tim and what was wrong with him. But lots of children around the world still experience rickets, and it's probably more of a calcium issue than a vitamin D issue. And rickets tends to go away in children when they start getting calcium in their diet. Osteoporosis, again, bone deposition is less than bone breakdown. The lysosomes in the osteoclast are busy dissolving away bone to get the calcium, and the spongy bone is most affected because it's the easiest to tear down because of its shape with all the trabeculae, and the lysosomes from the osteoclast just ooze their digestive enzymes out, and the bone dissolves and the calcium gets absorbed into the blood. And here we see healthy spongy bone on top and osteoporotic, I didn't make that word up, by the way, bone here being dissolved away by the digestive enzymes. And this is early osteoporosis. Yes, we we can see where it's being dissolved, and it has lots of little holes in here, but it's still not too bad compared to this. We see it, osteoporosis affecting the head and neck of the femur and the body of the vertebrae. So, because here's what it looks like in extreme cases where normal healthy bone here, spongy bone on the left, and after we've taken out most of the spongy bone on the right. Lots of things happen here. Bone mass drops because you're dissolving away the spongy bone. The bones become very porous and fragile. Compression fractures occur in the vertebrae. The bottom vertebrae, the lower vertebrae, the lumbar vertebrae collapse onto each other. So your patient with osteoporosis is going to become shorter in stature because the vertebrae collapse. You know, the upper vertebrae become wedged, and so they sort of spread out. And now your patient starts, not only is she shorter in stature because the lower vertebrae have collapsed on each other, but the upper vertebrae cause her to bend over and she becomes stooped. So she loses her, she shrinks. It's an easy way to say it. She shrinks in stature because she's, her vertebrae are collapsed and are also bent over. Triggered often by a lack of estrogen. The absence of estrogen after menopause is going to, estrogen stimulates osteoblast activity. Without the estrogen, without sufficient estrogen, you're not going to be able to keep up with the breakdown of bone. Now, an individual that has maintained a healthy diet over her reproductive lifetime up until menopause, exercise and lots of calcium, a varied and balanced diet, didn't smoke or didn't smoke a lot, healthy activities, drinking but not excessively, and that kind of stuff. We all know what a healthy lifestyle should look like. They are less likely to develop osteoporosis than your postmenopausal female that didn't do that. Or it can just attack the bones anyway. So lots of women in their 80s do not have osteoporosis. Lots of women in their 80s do have osteoporosis. There is still some estrogen being released through the adrenal glands, but not in sufficient quantities to overcome osteoporosis after it starts. So, but there are medications now that will stimulate bone growth. So there are drugs that will work against the osteoporosis. And it isn't, as I said, it isn't just because your patient didn't eat right, didn't exercise right, drank too much and smoked too much, and maintained a sedentary lifestyle. It's, lots of women that have osteoporosis did everything right, and they still got it, still developed it. Why don't men get osteoporosis? I'm glad you brought that up. I was about to say that. Men are susceptible to osteoporosis, but it doesn't occur nearly as frequently. The testosterone stimulates osteoblast activity, and testosterone levels drop off very, very gradually. There is no sudden drop off testosterone like we have in the drop of estrogen at menopause in the female. Men will continue to produce testosterone from the onset of puberty till the day they die. The numbers drop, the amount gradually declines. A 90-year-old male is still producing testosterone and is still producing viable sperm. Doesn't necessarily mean that he should become a father at 90, but he's still capable of doing so. So the testosterone levels decline slowly, and that gives a certain level of protection to the male. But men can still develop it, but it is unusual or infrequent. You know, you know, it's just, it is driven by the different type of hormone. So glad you asked that question because I was about to bring that up. Okay. Now, okay. So this is what happens here, and we can treat this. There are medications to stimulate osteoblast activity. As long as there is calcium in the diet, bone buildup can occur. So, and here we see, this is the wedging I was telling you about. The fracture has occurred down low in the lumbar vertebrae, but the upper vertebrae, the thoracic vertebrae, will start, you know, spreading out in this wedge shape. And as they do, the whole torso starts to bend over. And so we see we say that grandma sure is stooped over these days, or she's stoop shouldered or whatever, and she's shrunk. Well, you know, she has, you know, she's actually shrunk several inches off of her former adult stature because the vertebrae, some have collapsed and others have bent over. And then, of course, there's always the risk of having a hip fracture, because you can see this, the shadow area in here tells us that we've lost a lot of spongy bone at this point. Again, even more so here. You know, the fracture, that line may be the fracture right there, but notice how dark this is over in this side. Now this bone is healthier. There's some dark areas there. Osteoporosis in the hip, I mean in the head and neck of the femur over here. It's present, but it's not as pronounced as it is over here. This whole shadow area should be as white as the one on the left. But osteoporosis has attacked this hip, this femur, and has enabled it to, you know, I still think this is a fracture line right along in here. But it is slightly out of alignment. If you'll notice, like the line goes from here and then sort of drops. Because there was nothing underneath the compact bone. You can see the compact bone very nicely in the medullary cavity, but there's no spongy bone. It should be white in here because of all the, you know, the calcium that's present, like it is over here. I mean, granted, this side is being affected, but this side is the evidence of osteoporosis at work. Who gets it? 30% of all women between 60 and 70 years of age will likely develop osteoporosis. Your postmenopausal female will, you know, has about a 30% risk, 70% by age 80. Now, this is, you've got to take this, that 70% with a grain of salt, because there's a whole lot less 80. You know, if you take all the cohort, all the postmenopausal females that are between the ages of 60 and 70, and then you take all the postmenopausal females that are 80 and above, there's always less 80-year-olds than there are 70-year-olds, because, you know, the the 60 to 70-year-old cohort, you know, they're dying. You know, lots of women die in their 60s and 70s, and so that cohort shrinks. The survivors that are at 80 years old, there's less of them. Not everybody who's 70 makes it to 80, you know, just the statistical nature of it. And so the number of women at 80 is a smaller group. Now, is it really 70% chance of having osteoporosis, or is it just that, you know, in the reduced population that's left, does it seem to be occurring more frequently because they already had it? Because you don't suddenly develop it at 80 years old. Okay. Anyway, so always take lots of, always look at this, look at statistics with a very careful eye. Okay. We see that this 30% of Caucasian women will fracture their bones because of osteoporosis. This is based on statistical results collected from injuries. So this is probably a valid number. What does it mean? We don't know what it means. All we know is that Caucasian females will 30% of Caucasian females postmenopausal have fractured their bones. It doesn't mean they will in the future. It means that they have in the past. That's all it means. So, but we do know that estrogen is key. Estrogen levels drop drastically after menopause. And estrogen is responsible for stimulating osteoblast activity. And then, of course, testosterone in males tends to keep them from developing osteoporosis, but it can still happen. It isn't, males are not completely immune to osteoporosis. It just occurs much less frequently. Osteopenia, bone density is simply lower than normal. It may be the precursor to osteoporosis, but it doesn't have to be. It occurs when the female loses estrogen. It also occurs from unhealthy habits or unhealthy lifestyles, excessive alcohol consumption, excessive smoking, excessive habits, excessive eating, all these things, lack of exercise. Your asthma patient may develop osteoporosis, osteopenia, because the presence of their inhaler, their rescue inhaler contains a steroid hormone, a glucocorticoid, and that will inhibit osteoblast activity. Excessive use of that can inhibit bone growth. So, the thing that you have to ask too is if you're using your rescue inhaler extremely often. If your patient's using their rescue inhaler all the time, then maybe they need to go to a different inhaler or to a different type of medication, because obviously what they're doing isn't helping them. So, because your rescue inhaler shouldn't have to be used all the time. My wife has asthma, and she'll use her inhaler once or twice a week, maybe, because her medication keeps her asthma controlled. So, but if you have to use it, your patient's using it 4 or 5 times a day, that's excessive use. Yes, they're using it because they have to, because they need to breathe. Breathing is sort of essential. But whatever medication they're using to control their asthma isn't doing its job. And that needs to be, changed then. Okay. Osteopenia also shows up. This is sort of an unusual phenomena in your adolescent and young adult female athlete. It has to do with your females that exercise strenuously, to the point of exhausting themselves, and maintain zero body fat, or almost zero body fat. If you have a female athlete as a patient and she's 20 years old, for example, and she has asthma and she has to use her corticosteroid inhaler, and she has practically no body fat on her, and she exercises for 3 or 4 or 5 hours a day. Perhaps she's a distance runner, perhaps she's a swimmer, perhaps she's a whatever, but perhaps she just exercises. Now, she has very low body fat. Perhaps she has an eating disorder. Because many times your female athlete that has this obsessive exercise routine will also have an eating disorder, and they won't eat properly. Now, your swimmers, your average swimmer that swims, practices all day long for the Olympics, and they're in training, they'll eat 10,000 calories a day because they're going to burn 11,000 calories. Michael Phelps, when he was in training, remember the Olympic swimmer, won all the gold medals and silver medals and bronze medals. His average diet every day was 11 or 12,000 calories. Many of those calories came from his favorite food, McDonald's. But he was also burning those calories every day with all the exercise he was doing. Not the best choice of diets, but considering they probably weren't around causing any grief. But yeah, so your athlete, there's nothing wrong with strenuous activity when you're training like that, as long as you can keep a balance with the calories going in, with the calories coming out. But occasionally you'll get your patient that is a female, 20 years old, exercises strenuously, has very poor dietary habits, maybe even some sort of eating disorder, because and obsessed over fat. Maybe they have a poor self-image of themselves. A lot of things come together here. And what will happen is the low body fat causes their periods to stop. It's called amenorrhea. See, when we have, what will happen is with low body fat means low estrogen. See, the body fat is necessary for estrogen to be formed. Estrogen gets stored in body fat. The androgens that are produced by the adrenal glands are converted to estrogens in the adipose cell, in the adipose tissue, in the fats in there. So there's a lot of things going on here. A female athlete with very, very low body fat and an eating disorder will often see her period stop and also see her bone mass get weaker and weaker. Osteopenia will be occurring here. And particularly if she's using, if she has asthma and using her inhaler. So, they tend to avoid dairy products because of the fat in milk, which also eliminates the calcium that they would be getting. So it's not unusual if you have a patient that has all these characteristics, for them to say, oh, by the way, I haven't had a period in 9 months or 10 months or 2 years. And she's not pregnant, obviously, but there's all this is going on. Her has practically no body fat. So there's lots of, it's not a healthy condition that can occur. Okay, osteomyelitis. This is sort of something unusual. This is the infection of the bone. This used to be fatal because, and it can still be fatal if antibiotics can't touch it. But bacteria would get into the bone marrow and grow there. The anaerobic bacteria doesn't require oxygen would grow in there. You can see how it's dissolving away. It forms pus and grows inside the bone marrow and destroys the bone. And it used to be a killer before antibiotics. Now it can still kill, if particularly if it's the flesh-eating bacteria type. You hear about this every now and then. People that experience zipline accidents over rivers, or for example, if they a zip line breaks over a river and someone falls into the water, and they have a compound fracture, the bone is damaged, and bacteria gets in there, And it's not unusual to read it, oh, they ended up losing an arm and a leg because of bacterial infections. We're not supposed to have that occurring from bacteria, but we have a lot of antibiotic resistant bacteria these days. So, and it's difficult to treat. Paget's disease, abnormal bone growth that is not very strong. Bone is broken down, new bone is built, then it's broken down, and new bone gets laid down on top of it. For example, look at this is the ulna right here. Look at this growth taking place there. It enlarges and grows, and then it's broken down. The bone itself is very weak and brittle. It breaks very easily. We see it in the spine, in the pelvis, in the femur. Apparently, we see it in the ulna and the radius, and also in the skull. We don't know what causes it. Is it viral? Possibly. So this is what happens. Note the length of the femur on this side versus that side. The tibia on the right side of the picture versus the tibia on the left side of the picture. The shape of the pelvis is excessive, and the facial bones here. It does not affect intellectual capacity, but it does affect these bones. Abnormal bone growth, breakdown, rebuilding. The bones are very brittle and weak at the time. We don't know why it happens. We don't know how to treat it. We don't know, what causes it to occur in one bone and then not another. And it might even be autoimmune, because autoimmune disorders bounce around from system to system. And it may be, since it doesn't attack all the bones at once, it only attacks certain bones, it may be an autoimmune response too. So gigantism, acromegaly, and pituitary dwarfism. I've already mentioned what they're caused by. This is gigantism. This individual was, how tall was he? 8 feet, 11 inches tall. And generally regarded as tallest man. Ripley's or the Guinness Book of Records may have some disputes on that. But he only lived to be 22 years old. With a body that large, it's hard to keep good systemic circulation going. Most individuals with gigantism don't usually live past their early 50s anyway, but this was unfortunate for him. Just to give you perspective, this is these are high school. These are some of his classmates from high school, and they're of normal stature, like 5.5 feet tall, and he's double that. So, acromegaly, enlargement of the facial bones of the hands and the feet. The not like gigantism in that the whole body doesn't grow. With acromegaly, it's only the hands and feet and facial bones. With gigantism, they're all the bones. I'll go back here and look at this at him. It's too early in his life for his facial bones to enlarge. His hands are large because his whole body is large, but individuals that have gigantism will often have the same symptoms of acromegaly later in life if they live that long. Here we have a very well-known actor from the 1930s and 40s. His name was Rondo Hatton. Very intelligent individual. He used to be a sports writer before acromegaly developed. Look at the squared off jawline, the large nose, and the large forehead. He had very large hands. He was of typical average body stature, and yet he had acromegaly, which changed the shape of his face and his hands. And he turned that into a career in movies, as a monster, as a gangster, as some menacing figure, and he did very well with it. Characteristically, very large hands. Notice the length of the bones in the hands. The finger, we say that the fingers become clubbed. The feet, the toes, the fingers are rounded off. The feet get large. Body stature doesn't change, though. They don't get larger as the long bones are closed down. It does alter their ability to speak. The speaking, again, manipulating of the words and sounds with the mandible are affected. And you can see there's a close-up of Rondo Hatton and his face showing the changes to his bones that occurred. And he died, I think, in his 50s or early 60s from some heart condition. Pituitary dwarfism occurs again because of an absence of hyposecretion of growth hormone. These individuals are all, the average size is about 4 feet. The indicator for pituitary dwarfism and not achondroplasia, which I'll show you here in a second, is there proportional development? Is everything proportional in size? These individuals all have proportional development. Their heads, their torsos, and their arms and legs are all proportional to one another. Achondroplasia has disproportionate shapes. This can be treated with growth hormone, synthetic growth hormone, and it is not caused. It is not some. It's just for whatever reason. It's not an inherited disorder usually. It's not caused by a disease. For whatever reason, the pituitary gland stops making sufficient growth hormone. And let's see, question we had. Yes, it is. It is the growing. Let's see, Benjamin, was that growing backwards in age or getting old very early? So no, the individuals can age, rapidly. Their aging process there's a condition where the aging process occurs rapidly over time. Getting younger as he got older. No, but the opposite can occur. The opposite can occur where it's sort of the opposite, where you have a 12-year-old who looks like he's 80. So you can see that. I don't know of any condition that actually occurred like in that movie. So, yeah. Speaking of movies, here's The Wizard of Oz. And in The Wizard of Oz, the Munchkins were all pituitary dwarfs. And by the way, if you've ever watched the movie, you might notice that there are children in the background. Some of the extra Munchkins were children. So, but you'll notice they are proportional in size. Their heads and necks and shoulders and arms and legs are all proportional to one another. So these were all pituitary dwarfs, all 40 or 50 or 60 of them, however many there were in the movie. And by the way, Dorothy's dog Toto got paid more per week than the Munchkins did in the movie too, just to throw it out there. Anyway, now proportionate pituitary dwarfs are going to have a proportionate body. The achondroplasiac dwarf, and I want to wrap this up here real quick, is disproportionate in size. This is a genetic condition. The long bones stop growing in childhood. You get short limbs and a normal torso, and so you're under 4 feet tall. The head appears large, the torso appears large, but the arms and legs are very short. The long bone growth shuts down, and most of it is replaced with cartilage It is a mutation on chromosome number 4, and this is the most common type of dwarfism that you encounter. Mini-Me from the Austin Powers movies is an achondroplasiac dwarf. The little people, the different TV shows about the little people, those are all achondroplasiac dwarfs. The cartilage doesn't get converted to bone, and you stay under about 4 feet in height with an average sized torso, short arms, short legs, an enlarged head, and a very limited motion at the elbows. The elbows are affected. So this is what your achondroplasiac skeleton looks like. So a lot of cartilage that didn't convert to bone. And again, often a shorter lifespan, but not necessarily limiting. There are, again, most of the dwarfism we encounter is going to be achondroplasiac dwarfs. 70% of all dwarfism is this. Most pituitary dwarfs don't exist because they get treated with synthetic growth hormone, because their condition occurred only because they weren't making enough growth hormone. With the achondroplasiac dwarf, it's because of a genetic mutation, and that is that can be an inherited. Well, it is inherited. It is an inherited trait that gets passed on. So, okay, let me comment. Pituitary dwarfism can be treated. Yes, it is by using synthetic growth hormone. There are it will as long as it's administered while the long bones are still growing, that they can reach their adult stature. Now, there may be some complications from the hormones, but by and large, the individual can achieve the adult stature. Achondroplasiac dwarfs, it's a genetic disorder that can't be treated, at least not yet. So, okay, and that is everything I've got on bones. On Thursday, we'll start on muscles. So, and from the physiology of how the muscles work. In lab this afternoon, we're going to go over the human muscles again. So, and if you have any more questions, I love the questions, by the way. Thank you. I will be glad to answer them. Just send me an email, and I'll see you all later.